Morning, everyone. Just wanted to make sure that you can all hear. Um, Today, you're going to be without my usual backdrop and images. I'm afraid I've not been very well this weekend, and the way I look, you don't want to see what I look like. So, just wanted to make sure that the sound is working okay. It looks okay my end. So, if you could just let me know. So we've got Martin in. Good morning, Martin, and Steph. Hello, hello, and the return of Webbo. Here he is. Good to see you back, mate. And coined the phrase "Anata Monday." It's still sticking with people. Those that've been doing it long enough. Brilliant. Thanks, Becky. Thank you. Hey, Carol. Good to see you as well. Okay, so we've got a fair bit to get on with. And yeah, I've just had a look. There are 55 slides. So that's what's that? Less than one a second. So hopefully there's some filler slides in there as well. So we hopefully want to get this done today. But if not, then definitely by next week. Thank you, Becky. Thank you. Yeah, yesterday, if it was yesterday at 10 o'clock, there was no way this was happening. Right, so yeah, we've moved on to sciatica, and we were looking at this. We were looking at radicular versus radiculopathy versus referred, and yeah, it's your fault, mate. Your fault. This is often something that's really confusing for health professionals, but also for patients as well, and especially when you have symptoms and then you Google them, or even misinformation from other healthcare practitioners, and the label sciatica is given to it, but it needs to be a little bit more specific than that. It needs to be a little bit more nuanced. So we had a look at this. There are two main types of, so yeah, basically going through the different types of pain. So we're looking at referred pain. Two main types of referred pain. We've got visceral pain from the organs, and then somatic from the bones, cartilage, muscles, but not the nerves. And that's really key because it often looks a bit like nervy pain, but it doesn't have the same kind of pattern. And it's that kind of pain where when it's referred from muscle joint bones, cartilage, it kind of moves around a bit, and that can be really really frustrating for both practitioners and for um, the patient themselves as well, because they're going, well, one day it hurt here and then it was hurt down here and then it went down my leg, and so it's a very mixed picture, and we're going to see that some things are really clear and some things are a bit mixed. And then we talked about something called Kerr's sign, which we'll have a look at in a second, which is visceral referral from the organs. So organs are not highly innervated in terms of nociception, so in terms of like danger messages, like pain receptors, if you want to kind of drill it down into that simplistic kind of term. So something has to happen to an organ where it then gets for example, so say it's a liver, then there something will happen to the liver where the liver then starts to grow, or it starts to become infected or something like that, and then the infection or the growth gets so big it then starts to encroach on the musculoskeletal system. So and the nearest thing to the liver and the spleen is the diaphragm, and that's where Kerr's sign comes from. Okay, and there can be referrals from other organs as well. And I think I mentioned last week there's a couple of our students have had this with patients, and unfortunately, it's we've and I've had it as well with a patient where they've had shoulder pain that unfortunately was actually referred pain from their lung, and it was a lung cancer. And that was the reason why they had shoulder pain. And I did all of the shoulder tests, and they're all negative. So all of the special tests, all of the palpation, trying to pinpoint exactly where it's sore, and they were fine. They were absolutely fine. They can move their shoulder around, no problem. And that's what raised my suspicion to then send them to their GP to get checked, because it wasn't presenting like a musculoskeletal problem. And you can have lung cancer that refers to the shoulder as well. So there's lots of different examples of this. So one of the reasons why we get it is this. We did cover this last week, so just a quick recap. C345 keeps the diaphragm alive, and I remember this from lifeguard training years ago. This is going back some years, probably about 30 years ago, and we were taught about this nerve called the phrenic nerve. And basically, this is why we use stabilization techniques with neck injuries. And if you have any problems with the phrenic nerve, which emerges from C345, then it will basically switch off your diaphragm, so you won't be able to breathe. So that's why we stabilize the neck. If there's any risk of any kind of neck injury in sports, or especially in swimming pools with diving into shallow ends and all that kind of stuff. So, however, like I was just saying with the liver, so the liver would be under here. So if that is irritated for whatever reason, it can then irritate the diaphragm, and then messages are then sent to C345 because that's where the nerve emerges from. And also going into C345 are messages of sensation from the shoulder region. So what your body does is it goes, well, can't be coming from the diaphragm, must be coming from the shoulder. So it makes your shoulder hurt. And that's why we have shoulder pain with liver problems and spleen problems. It's very, very common if you search on Google for visceral referral patterns. They are well documented. Okay, so there are common patterns like lower back pain for kidneys, lower back pain for things like ovarian cancers. There's lots of things like that. So it's well worth having a look at those things, just to kind of give you a few more things to think about. So yeah, basically the messages get mixed up and your shoulder hurts, but actually it's the diaphragm that's causing the problem. So if you do have someone with shoulder pain and they do go through all the motions and everything is absolutely fine, then you should be thinking, right, okay, that this is something I can't deal with because none of my tests are positive. So what am I going to do? Was my justification for treatment, and there isn't one, because what can you improve if there's no MSK problems? So that's when you need to refer to someone else. So that's examples of referred pain and visceral and somatic. And last week as well, we talked about sclerotomes, and sclerotomal pain is pain from the joints, and that's really key as well. So if you have a look again for sclerotomes, let me just type this up for you. Sclerotome. So that's how you spell it, sclerotome. And if you have a look for sclerotomal referrals, then they are, again, very common referral patterns from the joint. So sacroiliac joint has got a common referral pattern. The hip joint has. The lumbar spine has. So have a look, because they often, again, mimic things like tendinopathies. And so you treat the tendinopathy and it's not getting any better, and it's because it's not coming from there. It's coming from the joint structure itself. Cool. Okay, so you can see already that diagnosing, in inverted commas, a reason for someone's symptoms that are referring somewhere can be a bit tricky. Here's the next thing that's going to make it tricky. So you then have radicular pain. Okay, so we had referred pain, which was from either the viscera or the soma, so the body. Then we've got radicular pain. Now this is specifically from the nerve root or the nerve root ganglion, usually sharp and shooting, and there's usually a clear defined line of pain. And this is very different to the referred pain, where it's dull and diffuse and often changing. This doesn't usually change. Okay, it shoots down, and it's very, very specific. Okay, so for example, like this one here, this is C8. Yeah, so there's some kind of ulnar nerve distribution with this, but it does go down the back of the shoulders as well, in between the shoulder blades as well. So people may not actually feel this one, but they might feel this one a bit more. And so when somebody has referred pain, but it's following the line of a nerve, then it's more likely to be from the nerve root. And then you would have to ask questions about whether they have any neck pain, whether they have any problems turning their head. And again, sometimes they may not have noticed it, and it's only when you go poking and prodding that you find the problem. Thing is, with this one especially, this is a classic. The posterior capsule and the infraspinatus, if there's irritation there, so a somatic referred pain, that mimics a C8 nerve root. It's pretty much the same pattern. Okay, so they'll have tingling sensation into their little finger, and you might have found this when you're doing treatments for people. They'll lie on the front and you're working around their rotator cuff doing manual therapy, and then they go, oh, I can feel that in my little finger, but you are nowhere near a nerve, yeah, or nowhere near the ulnar nerve anyway. So it's weird that they're feeling ulnar nerve symptoms when you're not pressing on the ulnar nerve, and it's because of the referred pain. No, it will be. It depends on where it is, Martin. So if there is a central nerve problem, so on the spinal cord itself, usually that will affect both levels, but it will also affect everything else below it as well. Usually, it's just the picture, I think, on this one has just got it on there as well, just to show that it's on the that part of the forearm, I think. But usually with nerve root issues, they are unilateral. Okay, so if it's a central problem, like a central cord problem, then it will affect both sides usually, and also the structures below that level as well. So we saw that guy last week with the reflexes, and he had massively increased reflexes on one side, and in particular his leg, but pretty much all of the reflexes were increased, and that's because of the level that was affected. I can't remember exactly what level it was, but it was in his neck. So that basically it would affect all of the structures underneath. Yeah. So that's radicular symptoms. Okay. Shooting, not dull, not achy, shooting sharp pain. Okay. So there are differences between the referred and the radicular. Then we've got the one that actually we need to be worried about. Although the radicular pain, yes, we should be worried about that, but this one specifically, because this means that we've got some loss of function. So radiculopathy has got nothing to do with the symptoms. It's a loss of nerve function. Okay, so you can have no radicular symptoms, no referred symptoms, but you can have a radiculopathy. Okay, the injury is at the nerve root level, and they will test positively, so have basically a bad test for reflexes, touch, and strength. So they'll lose their reflexes. Their reflexes will be dull. They'll have a loss of sensation around a specific area that nerve supplies, and there'll be a loss of muscle strength in the region of the muscles that nerve supplies. Okay, so a radiculopathy is where you do your neuro testing. So you need to do a reflex test, a strength test, and a sensitivity test. And those sensation tests, those sensitivity tests, they need to be hot and cold, vibration sense, soft touch, and sharp touch. Okay, so you do all four. And the reason why we do those is because of what we said previously with the tracts in the spine and what levels that they correspond to, because each tract carries a different signal. So you're testing all of the tracks when you do all of the testing. Okay, so radiculopathy is loss of nerve function. Radicular pain is pain that follows a nerve route, the nerve distribution, but from a nerve route. And then referred is either from the viscera, so from your organs, or from the muscles, joints, tendons, whatever it is. Okay, so there's various, those are the various different ways that you can get similar kind of symptoms, but for different reasons. Okay, so this is when it starts to get a bit tricky, because you'll probably get a combination of all three. Okay, you can have severe radicular pain, so the sharp shooting pains, but no radiculopathy, so no numbness or weakness, and that can also be the other way around as well. The symptoms can change over time. Then if you throw into the mix some referred pain from the somatic system, so joints and muscles, and a great example is if you have radicular symptoms, and that alters your gait, which then affects your sacroiliac joint, which then affects your gluteal muscles. So then you're getting a combination of the sclerotomal pain because of the issues with the joint, and it's irritated the joint. You'll then get a muscle referral from the glutes because they're not very happy, and we're also getting radicular symptoms from L5 or wherever it was initially where there was the initial problem. So it can develop over time and it can change, and that can be really, really frustrating. The danger messages from a disc herniation causing referred pain, radicular pain from a nerve root compression, and radiculopathy due to the insult to the nerve root. Okay, so you can have all sorts of different messages going on all at the same time. So this is why it's really difficult to pin one thing down as a reason for symptoms, and in this case we're talking about sciatica. Okay, so it's very, very difficult to do that and say, yep, it's definitely this, which why it makes me laugh when you see on like Facebook pages when someone says, oh, I've got I've got sciatica, and they go, right, you need to use a tennis ball in your piriformis, that'll get rid of it. Well, it will help if it is a muscle referred pain. Okay, it won't help if it's radicular. It won't help at all if it's radicular, and it won't help if it's a radiculopathy and you've lost sensation. It definitely won't help with that. So we've got to be really like sure where the problem is coming from, or have a good idea, so that we can effectively manage expectations, basically. Here's a filler slide. This is good. We can skip this one. So what the heck is sciatica? Even from Timon of Athens, I think that's how you pronounce it, in Shakespearean time, he talks about sciatica, that their limbs may halt as lamely as their manners. Lovely, like it. Good bit of Shakespeare on a Monday. So what the heck is sciatica then? It's a broad term which basically means pain down the back of the leg. It's not very specific, and that might be a good thing, because pain down the back of the leg is not often specific. So, but that's not very useful either, because automatically I think people think that there's a problem with their nerve, rather than it possibly coming from something else. And and also specifically discs. And I'm going to talk a little bit about discs in a second as well. Oh, here we go, right now. So we explored herniations a little while ago. So a little recap on this. So when a disc bulges, there is usually not an inciting event. So it's not something that all of a sudden it goes from completely healthy disc to a grade 4 rupture. Okay, so that it happens usually quite gradually, and you don't feel things at grade 2. You don't generally feel things around grade 3. It's when it gets to the end of the annulus, that's when it starts to hurt. So that's why people say, oh, all I did was bend over and pick up my, I don't know, my shoes, or I just sneezed and then my back went. And who could believe that my disc would go and it was just sneezing? And it won't be that. It's very, very unlikely to be that. It is something that has happened over time, and that sneeze was the last bit. Okay, so due to the slow nature of radial fissures forming, you can often have symptoms and people have no idea what caused it. And this can freak people out because they were fine one day, playing sports and everything, and then all of a sudden they're in crippling agony. So it's like, and that makes people feel very vulnerable about their bodies. So you need to explain to them that this is actually a slow process, and it was kind of like the straw that broke the camel's back. But it's not all doom and gloom. So we talked about this a few weeks ago. So here's a vertebra. Here's a vertebra here. Here's the disc, and then the annulus around the outside. And then this is a zoomed in view of this layer just here, which is the end plate of the vertebra. So we've got the nucleus here. We've then got the cartilaginous end plate, subchondral plate just here, and then the blood vessel just there. So only the outer few millimeters of the disc have a blood supply. But the end plate is not closed off. It's more like a filtration system than a plate. So even though it's called an end plate, there are holes in it. It's porous. Nutrients from the vertebral body are drawn into the disc via protoglycans. So that's how it stays healthy. So as you compress your spine and as it releases again, it draws fluid into the nucleus just here. So then that helps keep the disc nice and hydrated. Protoglycans are negatively charged and they draw in water, which is neutral, from the bone marrow. And we've also got chondrocytes, which are cartilage building cells, which help build the discs, okay, located within the discs as well. We've also got this enzyme, which is matrix metallopeptidases, MMPs, which clear away the waste. Okay, so all three of these things are working all at the same time and using the filtration system network, which is the blood supply that is going into the bone. So there's no blood supply into the disc. It's from the disc gets its nutrients from the bone, and it draws it in via something called imbibition. So it's like having a sponge. Squeeze the sponge, put it into a bucket, and then you let go of the sponge, and then the sponge gradually fills with water. So that's how discs maintain their hydration. And you can see here we've got I don't really like that word, but there we go, a degenerative intervertebral disc. So we've got little plaques in the blood supply, we've got little bits of calcification on the end plate. So it means that the transference of hydration and nutrients into the disc and the removal of waste is reduced as we get older. Okay, so a nice, quick, easy slide to work all that out, make sense of it, is proteoglycans are your DPD, so they're your delivery vehicles. Chondrocytes are your builders, friendly builder, and then MMP are your refuse collectors. Okay, so these guys are delivering stuff, these guys are building it, and then these guys are clearing away the waste. That's basically what's going on in your discs all the time. And what will happen is, if you have an issue with the disc, like in the herniation image that we saw before, so the annulus has been breached, so the outer ring has been breached. Proteoglycans have a party and they suck in loads of water. Okay, so the proteoglycans need massive wagons because they're like, woohoo, and they bring loads and loads of water into the disc really, really quickly. And the disc size can double, or the weight can double, sorry, in 4 hours. So it can double really, really quickly when there's an annulus breach. So like in that image that we saw just a little bit ago. So the delivery team are basically having a party. And yeah, I'm very proud of my Google searching that I was able to find a DPD party. So this is a disc herniation. You can see the annulus here. You can see as the nuclear material from the middle has breached the levels of the annulus as it's gone through. And we did a whole section on herniation, so I'm not going to spend too much time on this. But in a herniation, it's not just the nucleus, it's bits of annulus, it's bits of the end plate, and it's bits of bone as well. Okay, so when they examine it, this is what they find in a herniation: is these structures. If it's a large herniation, it can actually be better. Okay, but because it triggers the body's immune response to injury, and then that can help the disc be reabsorbed. So weirdly, if you have a big herniation, that's actually not a bad thing. Okay, it makes it easier for your body to clear it away. And then these are the different types of bulging that you can get. So a bulge is where disc tissue extends beyond the edges of the apophysis. Okay, so the edges of the end of the vertebra. Okay, and throughout the circumference of the disc. So if it's more than 25%, so i.e. it is spread. Okay, so if the whole, like this one here, this is a diffuse bulge where it's spread equally all the way around, and then this one is an asymmetrical bulge where it's spread still 25%, but more so to the right side than it has to the left. Okay, so anything that's more than 25%, you've got a disc bulge, and basically it's spread over the vertebral body. Okay, so that's your definitions. Then we have protrusion versus extrusion, and again we've covered this in the herniation section. So a protrusion is where the base, so the blue line, is thicker than the head than that one. Okay, so because that line there is thicker than that line, then that is a protrusion. So if someone has that put on their MRI report, then that's what that means. If it's an extrusion, it's where the head, so the red line, is bigger than the base, which is the blue line just there. Okay, so they look very, very similar, but they're given different names because one is wider, one is longer. Okay, so you've got extrusion and protrusion. The other thing that you can have is a sequestration. So basically this means that a sequester is secluded, so it's come away, and we've got a bit of disc material that has come out and now is floating in the vertebral canal where the spinal cord is. So that is a disc sequestration. There's a free fragment of disc material with no connection to the disc. Okay, so it's floating about in the vertebral canal. So we've all of those different types of disc herniation, whether it's protrusion, extrusion, sequestration, and whether it's asymmetrical, whether it's diffuse, all of those things will point you towards, and the size of them as well, whether they are more likely to be symptomatic or not, and whether they're more likely to heal quickly or not. So the bigger ones are going to heal quickly, and usually if you've got a sequestration, those ones are often reported to be the ones that are sore. Okay, so people complain of pain more often with a sequestration. Now there was a paper, I don't know whether I've got it on these slides, but it showed the normal aging of a disc and what to expect at the age of 20, 30, 40, 50. But these are on asymptomatic people, so it says like disc bulge, disc protrusions, and so on and so on. And on there, it didn't have disc sequestration, and it's because those people are usually symptomatic. Okay, so asymptomatic can be most of the other things, but symptomatic is usually that sequestration. Easy for me to say. So then we've got this, which is your posterior longitudinal ligament. Covered this, seems like a long time ago now. We've been dealing with the lower back for a while, and that can block the bulging of a disc. Okay, so if there is a disc bulge that is contained, then that means it's not broken through the posterior longitudinal ligament, so it's not broke through this ligament. If it's uncontained, then it's broken through the posterior longitudinal ligament. Uncontained are surprisingly less trouble in the long run because the immune system can help with the clear up. Okay, so again, if they burst through this level here, they may be, well, it depends whether they're connected or not. So if they're unconnected, so a sequestration, that can be very painful, and usually is. But if it's a bulge that's come through, then the bulge can be reabsorbed and is usually less trouble. Okay, so and it's because of the exposure that it's getting to the rest of the body, so the body's able to attack it basically and clear it up, and get rid of the bulge. But if it's there, but it's behind the posterior longitudinal ligament, it's kind of being protected by the ligament. Okay, so it may be symptomatic, less likely to be, but nothing else can get to it because it's protected by the ligament. If that makes sense. Hopefully that makes sense. Okay, then we've got different locations of herniation, and this can determine what type of symptoms that you get. Okay, and this is what I was alluding to earlier. With what Martin said, with C8 looked as if it was going down both arms. Now, if the herniation is central, it's not likely to cause ridiculous symptoms because it's going into the spinal cord. It's not pushing on a nerve root here or here. Okay, it's pushing on the cord itself. If it is causing ridiculous symptoms, then it's usually a serious one, i.e. cauda equina. Okay, so it's big enough to, because at that stage, the cord doesn't look like this. It looks like lots of nerves coming down. So if it's squashing the nerves, that's just like squashing the nerve root. Okay, so that's why cauda equina can be really problematic. So centrally, not likely to cause ridiculous symptoms, but again, depends on the level. If it's paracentral, which is most common, the annulus is weaker in that position, and it's less protection from the posterior longitudinal ligament because that runs centrally. Okay, so it's coming out to the side of the posterior longitudinal ligament. It's not able to be contained by it. Okay, and then foraminal, so this is coming out right at the side. This is really rare and can also irritate the dorsal root ganglion, which was that bunch of sensory nerves coming in. Okay, so that can really irritate that. But again, this one's rare. So this is the one that's normal, or most reported, most common. And now, hopefully, because you can see the direction of the herniation, you can see that it's more likely to encroach on that nerve root that's coming out here. Okay, coming out the side of the spinal cord. So, what makes it hurt? We've got a couple of different things. So, the nerve root that's been affected can be sensitized in different ways. This is a really nice way of thinking about it. So you can have something called bowstringing. So if you push on a guy rope, then it absorbs the force to a certain extent. Obviously, if you keep pushing, it's gonna break. And similar with a nerve, it can then start to deform the nerve. So let's say this is the nerve root here. This is near the foraminal space, and this is where the disc bulge is. So it's pushing against this nerve here, and what it's doing is it's pushing it that way, which then bows this this guy rope. So it's basically bowing, creating like a dent in the nerve, and that constant dent into the nerve can sensitize it and annoy it. Okay, and that's where you get a mechanical irritation. So it creates this, but it is basically like a dent in the side of a nerve. So yeah, there we go. So it's kind of like this, but without the compression. So if you imagine that this coming through and then pushing on the nerve, but it's not completely squashed it, it's just bowed it. Then we've got compression, and this is what we usually imagine is happening to a nerve root after a herniation. So the herniation has come out so far that it's completely squished the nerve. All right, so and that would be a good argument for someone to have radiculopathy symptoms, because they're not able to pass any information backwards or forwards past this point, because you're not able to receive any sensory information because it's squashed, and you're not able to send any motor information because it's squashed. So you lose power and you lose sensation. Okay, so that would make sense. Whereas with bowstringing, you've probably got an irritation to the nerve, but because the nerve is not being fully compressed, you can still feel stuff and you can still move things, but there's a sensitivity around the nerve that has irritated it. So you've probably got radicular symptoms. Okay, but it's not always that simple. So the things that can also create mechanical irritation is the nerve, because we've seen pictures of the nerve over the last few weeks and where it comes out. There's not a lot of room. Okay, there's not a lot of space. So you can have deposits of fat in the area. You can have little osteophytes, little bits of bone growth in the area. You can have changes to the blood supply, and you can have hypertrophy of the ligaments as well. So especially if there's been in a car accident or something like that. So all of these things are starting to fill the space where the nerve emerges, and then it just gets crowded out. So there's no room for the nerve, and then the nerve starts to get irritated. Okay, there's limited space at the intervertebral foramen anyway, let alone if all of this stuff is encroaching on that space as well. So we've got a few different ways that you can have mechanical irritation. So what then happens? Here we go. Nerves are really, really blood hungry. They when you have a problem with a nerve, the body starts to give up other areas of the body to go, right, we need to protect this nerve. Okay, so nerves are really, really precious to the body. The propulsion of a nerve impulse along the axon requires energy. Okay, so for it to propagate along this line and then reach its destination, it needs energy. Okay, a mechanical deformation of a nerve causes a conduction block. So basically, if there's bowstringing, or it's crowded out, or there's compression around here, then the nerve conduction can't pass through. The nerve then can't function, and the impulse fizzles out. Okay, so it then can't send the impulse anymore, right? So this is what happens when you have this mechanical irritation. So we've got a couple of things that can happen when you have mechanical pressure. It can be irreversible, or it can be reversible, right? And this is why we need, if we see these kind of signs, we need to get people looked at really, really quickly, because if this is why the cauda equina is such a important topic to discuss and to make sure people are checked out, because if they have a loss of function, especially, I mean, in Cauda Equina we ask about bowel and bladder changes. If there are bowel and bladder changes and they are not remedied quickly, they will be permanent, okay? And it will be an irreversible conduction block. If they're seen quickly, it can be reversed, okay? And the mechanical irritation can be removed, and then the nerve then starts to function normally again, okay? So timing is really, really key. This is a one way that you can get a way that everybody will know about. So reversible conduction block from mechanical irritation. So the common perineal nerve with the superficial and deep perineal sensory distribution is here. So if you cross your legs over and compress that nerve, then you'll lose sensation in your foot. But then when you remove it, it's better again. But obviously, if it's a disc bulge in your lumbar spine, you can't do anything about that. Okay, so that needs a surgical intervention. But if you can remove it quickly, the sensation comes back. Okay, so that we've all experienced that at some point. So what happens is we'll have normal blood flow. So blood in is under high pressure, oxygen is used by the nerve, and then blood out is at low pressure. So that's normal blood flow. If we've got loads of stuff in the way, loads of bits of fat, some osteophytes, some ligamentous hypertrophy, we've got blood in at high pressure, oxygen used by the nerve, okay, but then the blood is struggling to get out. So then we get venous congestion. So we get a bit of a backflow of venous blood, and the capillary bed is not able to clear properly for the nerve. So then the nerve starts to become dysfunctional. So the venous congestion, the blood struggling to get out, there's a buildup of fluid, and then the edema causes mechanical pressure. That mechanical pressure and edema causes venous congestion, which causes edema, which causes more mechanical pressure. And it's this cycle going round and round and round. So unless we sort the problem out, unless we sort the blockages out, then it's going to become a problem that is irreversible. Okay. So this is a positional reversible conduction block Phelan's test. Okay, so if you do a Phelan's test, you're compressing the median nerve, and then you'll reproduce the symptoms of carpal tunnel syndrome. But then as soon as you release the hands, then it's all back to normal again, and it's all fine. Okay, so that with a reversible conduction block, there is no underlying structural damage to the nerve. Once the edema has cleared, everything is good. Okay, and that's what we want. We want something that's dealt with really quickly. So if there's an irreversible conduction block, so we go down this, if we remember this, okay, so drainage is impeded, the blood pressure is high, trying to get in, oxygen is being used, but then the blood's struggling to get out, so we've got this congestion, which is backfilling everything, creating swelling. Now blood is struggling to get in because the outlet is blocked, okay, and then we get ischemia. Okay, and this is where the nerve isn't getting enough oxygen to meet the nerve tissue demands. Yeah, because the oxygenated blood can't get in because of the backfill from the venous system. So now we don't have any nerve impulses, because without blood, the myelin sheath and the axon will start to die. And this is what I mean by irreversible. If that goes on for any period of time, then once that nerve tissue is gone, it's gone. Okay, so what we need to do, last thing, early radiculopathy testing is key. Okay, we need to test reflexes, test myotomes, test dermatomes when anybody complains, even if you think, oh, it's just referred, or you think, yeah, it could be radicular. We need to test the reflexes, the myotomes, and the dermatomes. And if you don't know how to do it, then you send them to someone who does. Okay, and then that will reduce the likelihood of something becoming irreversible. Okay, cool. And that's it for today. Yeah, sorry about my lack of faith. I'll be back next week, that's for sure. You all look as if you're in stunned silence. There's been no questions. Hopefully that was really useful. And yeah, if you've got any questions about this session or the sessions that we've done before that led up to this, then give me a shout. There's a couple of extra little bits that I've got left to finish on this one. But yeah, I'll finish those off next week, and then we'll move on to up into the thoracics. Okay, cool. See you next Monday.